It's so quiet in here. Good morning, everyone. My name is Kim Eichhorn, and I have a special guest with me today, Olivia Rossi. You'll see another name up on that slide. Kayla Ott is a rehab engineer out in Chicago, and she is 38 weeks pregnant right now. So when we when we decided to do this together, she was clearly not pregnant. And thankfully, at the last minute, Olivia decided to step in and tag team with me. So I'm really happy to have her here and all of you here. Um, if you were in the plenary session, I found it very thought-provoking, very interesting. And I have a lot of, appreciation for the things that AI can do. So no shade to AI because it's probably listening to me right now. But when we today are going to be talking about elevating critical thinking and clinical decision making, we are very much going to be focused on the human factor, human relationships, and how we, work together. To come up with creative solutions. Um, Before we get started and introduce ourselves in a little more detail, I must tell you that all three of us receive salary from the Department of Veterans Affairs. So anything that we say does not reflect official views or policies of the United States government or the VA. And if we happen to mention any specific products, those are also not endorsed by the Department of Veterans Affairs. So very quickly, we'll do quick little introductions. As I said, my name is Kim Eichhorn. I am a speech language pathologist and have been for over 23 years at the VA. I have some board certifications in neurogenic communication disorders, and I have my ATP as well. And so I have worked across acute, inpatient rehab, outpatient rehab, hospice, all the things. And I'm the primary clinician in our ALS clinic right now. So done a lot of things over my 23 years. Olivia.
Good morning, everyone. So my name is Olivia Rossi. I am a rehab engineer at the Chicago VA, Hines, not the one here. I have been a rehab engineer for 3 years. Previously to that, I worked at a nonprofit based in Tennessee, which is a very different world. I love both of them. I appreciate both of them. I love serving people with assistive technology needs in both aspects. My background is in engineering, so I did a bioengineering graduate or degree, and then I got my graduate degree at Pitt for rehab technology. So I've kind of combined that into making myself a rehab engineer and then getting my ATP. Yeah.
Yeah, thanks.
Mhm.
All right, so you all can read, but over the next couple of minutes, we want to really dig deep into how we think about the assessment piece. And I know we heard about that a little bit in the plenary. Talk about how cognitive and language functions might impact both your assessment, your device selection, and the training process. I mean, I am a speech pathologist, so the card would be revoked if we didn't talk about that a little bit. And then talk a little bit about training plans and how to maximize patient-centered goals. So before we go any further, like this might be a little different because I don't want it to be death by PowerPoint. So we are going to dig right into some case studies here in a little bit after we talk. But before we do that, we want this to be very interactive. We want to know what you're thinking. We want to just like talk through things. So like just generally speak, who is in the audience? First, are there any other speech pathologists in the room? Oh, yay! Okay. Who else is in the room? What do you guys do? ATP? OT? PT? Yes, I know you over there too. Okay, cool. All right. So next, audience participation question. When you think about assessment, like what is the very first most important thing that pops into your brain? Like the first question you have? Client goals. I love it. Any other first things you think about? Yeah. I think for me, it's probably a tie between what's the diagnosis and then who is this patient? So for me, I kind of always start with, I think one of the things that we tend to lose sometimes in healthcare and with pressures is like, who the person is and that relational piece, because for a whole host of reasons, not because we don't care, but just because like who they are and what matters to them sometimes can get lost. And so I think everybody in this room would probably agree that in order to do a really good assessment, we really can't work in silos. However, not a lot of places are set up for us to not work in a silo. And I'm curious, in any of your current settings, do you have a comprehensive team approach to assessment? What does that, do you have all these players in the game or access to them? How does that work for you in your process? I see some head shaking. So somebody with an interdisciplinary collaborative like clinic space, want to share what that looks like for them? Mhm.
So it find out what all of their goals are and kind of work together to have the best what's going to make sense on.
Yes, perfect. So in pediatric clinic, if y'all couldn't hear, like easy access, to PT, OT, and speech. And I think those are the first people that we think of. Does anybody work in a school or with schools? Okay. You had. Sure. Yeah. And so I think, and you bring up a really good point about if you are in a more siloed space or not in a place where you are assessing them at the same time together. I mean, sometimes that's just not feasible, right? Having this idea of an interdisciplinary team chat or space or discussion. I think, Microsoft Teams and things like that have done a really, you know, does a really nice job of connecting us and sharing relevant information to the next provider who's going to see them. I'm thinking back just yesterday to ALS clinic. I had a covering OT with me, and the veteran brought up something about computer access. And so I was just like, when I passed them in the hallway, because we see them individually, I was like, hey, I know they might bring this up. I'm on it. I'll get with so-and-so. Like, you can address all those other things. I'm aware of this, and we'll run with it on our follow-up visit. So I think making sure the players in the game have connection, even if you don't have that really specialty collaborative space or a collaborative consult where you all see them together. I mean, in an ideal world, right? But that's not even possible, even in, really cool places like the VA where things like that can happen, doesn't always.
I think like some sort of I kind of think of it as like a handoff. Like when you like pass in the hallway, you're like, they talked to me about this.
Yeah.
We can both like work together because like if it's computer access on a speech device versus something else, like we
Yeah.
need to work together.
Now comes the probably most important part to me. My bias in all these years is I think we do a really good job about trying to match the person to the technology and picking something. And after all, whatever your roadblocks to actually get and timeline to get the technology to them, then comes teaching them how to use it. And so I want to spend a couple of minutes from my speech pathology brain about teaching and training. And it goes back to that one thing that I said about one of the first things I think about is the person, right? And part of that is how they're functioning from a cognitive standpoint, their language skills, but also mobility, vision, hearing, all the things that we assess for, right? But I think sometimes wheeled mobility, I think most people are on board, they want to get around, they see, but sometimes other technologies that can actually help facilitate their independence, maybe they're not ready for it. If you think about, I should have probably disclosed, I'm also in a PhD program right now for healthcare ethics. So a lot of the way I think about these things has been supported and maybe changed and modified and transformed. And I really think about that caregiving piece and care receiving piece. And sometimes just because we can and should, and it's available, and you could be able to do X, Y, and Z, and you're telling me that that's what you want to do, doesn't mean they're totally ready to receive the care that you can provide. And so I'm just sort of like, so that's part of the whole person piece for me. And then also what their social connection and support is, because all of that matters to help them either accept and embrace and go with the technology and then implement it when you're not with them and generalize it to other situations in their environment. Speaking of, where are they using the technology and then how we teach them to use it. And I think we do a good job, and I will stand corrected if you correct me right now. I think we do a good job of collaborative assessment. I'm not convinced we do a great job with collaborative training to make sure the functional needs are met, the technologies are maximized, the quality of life is improved, we see efficacy, those kinds of things. I'm not 100% convinced. And so when I think about, from my speech pathology brain, about training a skill or training a technology, there are sort of three buckets. So initially learning the skill. Think about something you learned riding a bike, initially learning the skill. And then you get better and better at it. And as you do it and you repeat it more and more, then you're like, okay, I can do this on a flat road. Now I can do it on a windy road. There's that mastery and generalization piece. I can go up and down hills. And then even though I haven't ridden a road bike in years, I could probably still get on one and do it, right? So maintaining it over time. And that's a very motor procedural example that I'm about to sort of flip on its head when it comes to learning a new higher level cognitively taxing skill. And so the literature talks about different training models, and there is so much evidence to support durability of learning in trial and error methods. And those methods are in this conventional instruction space. So people learn from their mistakes. Cognitively intact people learn from their mistakes. You do something one way, you're like, you reflect on it. That's what your frontal, they help you, monitor what's happening. They give you feedback, you make adjustments, and then you don't do it that way again the next time, in theory. I mean, some people just never learn from their mistakes, but that's a whole nother talk for a whole nother conference. But if you have an intact, I mean, that's what we do. Think about Montessori programs in preschool and that discovery learning. And a lot of what my PTOT colleagues do, there is a ton of literature, even about the durability of learning when you learn from your mistakes. So that would be putting somebody in their new power chair, walking them through how to turn it on, adjust the speed, go over the seat adjustments, Okay, let's go for a spin. Whole task model. All the steps, ready, set, go. Ooh, that was too quick. Let's slow down. And they recognize, I would like to slow this down a little bit. I don't quite have this yet, right? So that's the convention, and they're learning from that. However, when you are not cognitively intact, or you have an aging brain, like we all do, something shifts in terms of your learning. And the evidence really supports a much more systematic way of teaching. So our kiddos with developmental disabilities, our adults with mild cognitive impairment or post-stroke. So where you might see some shift, those might be some really, concrete examples. Systematic instruction breaks that whole task model down to individual steps. So let's think about teaching our parents how to use their new smartphone. All right, you're all smiling and nodding because I just made this real. So rather than, Mom, if you put a reminder in your phone, you'll remember to take your meds. If I want to teach my mom to put a reminder in her phone to take her meds, first, all I'm going to do is have her find the reminder app. Find the app. I mean, and I'm over exaggerating right now, but like for point of example, find the app. Okay, then find it and open it. Close it, find it and open it. Okay, she's got it. She knows what it looks like. She knows where it is. She can get to it. Now she has mastered that piece. All right, so we're going to put a plus. That's to add. And so let her walk through and systematically, hierarchically increase those steps to what you're trying to teach, what that whole task is. And so I don't want her to just go exploring. If I see her going someplace I don't want her to go, oh, wait, mom, not there. So you want to minimize the mistakes so that they learn it correctly the first time or the sixth time or however many times you need to get it. Once she's got 75% of the steps for this, then we add the next one and she's got it right and she's confident. So then I do that. And then we start talking about some recipes or vacation or whatever. Mom, let's put a new reminder in your phone. Can she do it without me helping? This idea of systematically training the right way, and then distributing the practice, adding some distractions. So for training assistive technologies for people with cognitive impairments, I'm going to argue that that takes time and teamwork and knowing the cognitive functioning of your patient. I mean, I'm sure everybody in this room has had somebody that has struggled to learn something you're trying to give them to help them. Is that a fair statement? Yeah. And so I think one of the things we need to do better as a group is not forget this training piece and rely on our speech pathology friends, our OT friends, other members of the team to actually help with the training piece of the technologies also. All right, I'm going to get off that soapbox. I could talk about it all day. All right, so here is a really cool framework from some really smart speech pathologists who do a lot in brain injury, have done a lot in assistive technologies. There's published studies. And so if you're a geek about cog rehab like me, they have two fantastic books, Optimizing Cognitive Rehab, which came out in 2011, which is what this screen is from, and then Transforming Cognitive Rehabilitation. Really helps you think about how you teach people and get it to stick so that it has a functional impact. And we know assistive technologies or our devices, the reason people don't use them is we either didn't get the right one to begin with, or they didn't learn how to use it and don't see the utility for their function. So we can nip that in the bud at the beginning. And so what you'll see here is just a very quick scheme. I promised case studies. We're getting there. Planning. Who are we teaching? What are we teaching? Where do they need to use it? Answering all those WH questions. And then how am I going to teach them to do it? And so in that acquisition, mastery, maintenance, that training is where that implement, their framework is called PI, plan, implement, evaluate. So we've already talked about this, minimizing the errors, lots and lots and lots of correct practice, getting it right, and then distributing that practice. Give you a break. Do you still have it? If you don't still have it, I jump right back in and say, okay, let's pick up where we fell apart and try again. And then do more real life applications and then see how it went, within the session, in different sessions, self-report from family. Where are things breaking down at home once you issue that technology? So I think what I hope I have been doing is building this case of, yes, in the assessment phase, it helps us get the right piece of technology to the patient to meet their functional needs, right? I view collaborative work as a strength, not a weakness. I will not stand here and pretend to know things I don't know about, and I will rely on you for your knowledge and expertise. And I think that we are better together and probably better with a little bit of AI, but we'll see. Enhancing communication, and then really what matters, you guys said this from the outset, like what are the patient's goals? What are the client's goals? That their experience is good, and hopefully like When I know I have people who have my back or who are going to help me think through are really complicated or are really heart-wrenching, right? I mean, that's part of this too. That I feel better about what I was able to do for this person, and it makes me wanna have to face this hard thing again the next time, right? And so with that, Olivia, you wanna pop our first case and we'll all get to talking.
This is the interactive part, so listen up, y'all. So case one, we have a 48-year-old right-handed individual assigned female at birth, Parkinson's disease, with bilateral deep brain stimulation. So 11 years into this process. Some upper extremity tremors controlled with that simulator, but still kind of a little bit of clumsiness. Next for ambulation, short distances with the two-wheeled walker. Other mobility devices though, so it has a manual chair and a power chair. So keep that in mind. Right upper extremity is good for computer use. I think it's on the next slide. And power mobility. Hearing aids, no glasses, married, has 3 kids. We have more info. I will go back and forth if you need. So for verbal communication, it's functional, but secondary to dysarthria, it's increasing, or frustration is increasing. Notable right fatigue throughout the day because she uses a computer heavy job. So no specifics on the computer, but familiar with Windows and iOS, utilizes touch access on the smartphone. I believe it's an iPhone, clumsy, a little bit clumsy. But the main goals here were reduce the frustration with communication, especially after that frustration earlier, and then expand computer access throughout the day, kind of, because that seemed like the pain point from 2 bullet points later. So for the main activities, face-to-face communication with the family, medical providers, others, I'm sure work at some point. Social communication, so using our 2025 world, social media, email, texting, all of that. And then the computer functions. So these sound like job things. So word processing, emails, internet browsing, work needs. In the context, there's a house, there's a home, work. Also, we're dealing with this client in the medical appointments, community, social. So they have a full and robust life. So we're gonna kind of go to you guys. What do you think about this case so far with these needs? Any things that kind of like pop out immediately to you of either a device or something you think might be tricky too? That's something I think of a lot.
Oh, yes, hi.
I don't believe so.
No,
Oh, yes, thank you.
I'm gonna be a talk show host so you can hear each other. How about
I
that?
forgot about that.
Yeah. Okay, she has Dragon on the computer, so no, she does not.
Anybody else? Thoughts? Dragon's a good suggestion.
Oh, I like this.
Is she currently using any accessibility settings on her phone or her computer?
Don't believe so. Also,
Not
very
yet.
good.
Mhm.
Over here. Get your steps in, Kim.
I'm loving this. And you get a car.
We can't promise that we work for the VA.
I'll of course bring up my speechy brain here and say communication device that would allow her to do all of those computer tasks on it at the same time and look at different access methods.
Love.
I love that idea.
Oh, sorry. I guess my thoughts are going to, as like she's a joystick user. So I would be kind of looking a little bit at some of the accessibility settings in her iOS. There's a lot you can do with assistive tech, and perhaps it seemed, I think I saw that it was frustrating from her manual dexterity trying to she's clumsy with her touch access. So I would probably be looking at some of those accessibility settings in that iPhone, and there's lots of different devices that you could use instead of just touching. You can use a joystick mouse, for example.
For sure.
Aside from my follow-up, I would probably really heavily lean into exploring mainstream technology options first and foremost, given the fact that she uses a diverse range of mobility methods. So they're going to be more portable, and able to kind of adapt with her depending on what she's using that day, different things. And she's probably still in that state where there's a higher rate of like stigma and whatnot since she's in a progressive declining condition. So
And she's 48 too. Yeah, she's in
Yeah.
lots of places. I just.
I have a similar case now, and what we've done is there's like a adaptive phone holder that you can wrap around your neck, and it's like wired, so you can position it where you need to. She'll have it in front of her to hold the phone. She uses a stylus, but it can be positioned in front of her, or she even like if that starts hurting her neck, she leans forwards and put it like kind of lands it on the table so she can still see it and then bring it up as she needs to. So it just holds the phone for her.
Yeah, I love that. Is there someone over here? Oh yeah.
Yeah, I would say like Google's Project Relate app for communication as a bridge kind of before she's getting to like a full communication device, because that can just convert some of that dysarthric speech into automated speech for those times when it's really bad for her.
Found out about that last year and I am very into it.
Yeah, I love that. I love it because, and so I'll talk for a minute about what we ended up doing, what we did do. I don't remember what's on it, so I don't know. What we ended up doing is we maximized accessibility options on the things that she was already using. I love the text to speech idea with Dragon, but that dysarthria, gosh darn it. To your point. Well, we talked to her about, what she wanted and what her options were. So, I'm saying like we did this, of course we put a bunch of things on the table. What we ended up doing for work was we did take that communication device idea. If you remember, even though she has DBS, she still has tremors, some trunk control issues in terms of movement, making, gaze access a challenge because she's moving. So what we ended up doing was taking that route with Windows-based, using, computer access that way, but we paired the gaze with a switch. And so she would basically use the eyes to point and the switch to click on her axis, which helped her accuracy, her speed, and her fatigue. So she ended up, to your point, like she's sitting in one space for work. So that was like her now work computer. And she would, at the end of it, sometimes she would use the communication software. Sometimes the dysarthria wasn't that bad at this point, right? So that was sort of her, big picture, multiple solutions for somebody who had lots of functional needs. And we did, I totally have aphasia. What's the Google called?
Google Relay?
Google Relay. Yeah. To help translate some of that dysarthric speech, which I think there is a really fabulous application of AI in case you're listening. All right. Was there a hand? Did I miss a hand? Oh, let me turn it back to you. Sorry.
Yeah. Anything else on here? No? Yeah, just the training and maintenance. I think because she's also in so many different environments too, being able to translate it between all of those environments, and then also having a family and caregiver orientation is kind of key. I think for me personally, like troubleshooting is always something that kind of pops up, and that's kind of the most callbacks that you get. So bringing in family at the same time while you're introducing it to the client of like, these are some troubleshooting things maybe, so you can kind of keep going with it, and not get more frustrated with your new technology.
And I'll add, I mean, she's young. She's already a heavy technology user. So the learning here, the training, the acquisition phase was not that burdensome. Like she was a very quick study, and, trialing these technologies in real time. Oh, yes, this would be really helpful. And then to Olivia's, but that wasn't the end. We were available for, troubleshooting. All right, this is glitchy for me. How do we speed this? Those kinds of things.
We'll get case 2 going. All right. So 72-year-old right-handed individual, assigned male at birth, ALS for 6 months. So currently ambulating short distances, endurance concerns, but coming in, I think with 6 months in, you're not having your supportive devices yet. So right-handed upper extremity is pretty good for gross, but for the fine motor tasks, using the left hand, I believe. Yeah. Hearing aids and corrective lenses. So both those, and they're bifocals. Functional communication currently, am I speaking on mic? With respiratory, endurance and volume. So kind of with the communication. Clarity issues when he's tired. This gentleman is widowed with 2 adult children. He currently lives alone. In his past career, he was a postal worker. He recently stopped driving. So the main activities right now, communication with family and medical providers, probably going to a lot more doctor's appointments. Social communication, text messaging. And then, virtual communication. I didn't see that earlier. With family via video. So that's kind of an added bonus sometimes. E-reading, simple gaming, emergency communication. I feel like that I see quite a bit with ALS. And then for the context, he's at his home by himself. Remember, medical appointments. This gentleman goes to church and Hail to Pitt football games, social outings, a little bit of shopping. So now I will again turn it back over to y'all. Any big thoughts? Do you want me to run around?
I don't mind. Okay. Or what didn't we tell you that you think you need to know?
So that would be like if an emergency happened and he's by himself, like how is he reaching out either to call 911, call a family member? I also like to add unlock the door or have access to his environment. I would say
Yeah.
yes. Yeah. So
Like, what are all the things you're thinking?
mobility and just life. It's a big guy.
Wanting like home modification or just
Let's hold on home modification. We will be here all day.
If he's living alone, and he has ALS, we're going to have to consider the progress over time and the need to have caregivers coming into the home, allowing access to the home, maybe identifying them before they come into the home. The emergency access, like you mentioned, communication is going to be tricky. But yeah, a lot of electronic aids to daily living I see in his future.
I don't know about everybody else, but in Maine, where I'm from, if somebody comes in with ALS, it's an immediate rush. So we are power wheelchair group 3. We're doing that immediately. We're doing it as fast as we can. And then we start taking a peek at the other stuff that we can kind of systematically work on.
I think that. There we go. I think that's a beautiful point. What if he doesn't want it? How do you guys handle that? I'm just curious how
It has happened, actually. I had a person that came in with atypical, no upper extremity function, went with an e-drive. He trialed it, loved it, said after, I don't want it. Therapist cried. I kind of did too. We talked to them. So did the doctor. It was his choice.
thank you for bringing that up, or I kind of made you bring it up, but sorry about that. But thank you for being vulnerable and sharing that, because I think one thing that we don't talk about in this space ever is how hard this is. We see people on their worst days. I think, not acknowledging that piece really does contribute to and exacerbate, provider moral distress and burnout. We have enough, stress and pressure from timing and productivity and cost and deny, like the back and forth. But again, that very human aspect of like who you are and who they are and knowing that you can help. And knowing that when you help and do all the things right, you can't make it stop, right? I went into this as a therapist. I do a lot in hospice and palliative care. I have in my career. And so like there's this moment, there's this piece of what we do as providers where you're like, how do I make this not suck less? Because that's about all I got. And that can weigh on you. So I'm sorry for making you bring that up, but thank you for going there. Yeah, I feel like it's something like we should talk about.
Same thing, the same individual that came in. I mean, new diagnosis, very similar circumstance, honestly, because most of them are, let's be real. So yeah, the conversation about the vent, didn't want that either, obviously. But I mean, at the end of the day, we provided the best service we could. We gave them all the options that, you know, they could choose, and they just chose to kind of live with the dignity they had left.
And that is 100% their right and doesn't hurt us any less. Okay, so we've talked about this lovely, strong, independent gentleman who got a really, really bad diagnosis and things are starting to decline. We talked about, you know, home, we talked about power mobility. We've mentioned some communication loosely. What's everybody else thinking?
I'm thinking about his social access too, how he wants to go participate in his other functions as well too. The thing that I think was missing from the information we gave out was, where's his home located? Is it near public transportation for his new mobility device? Is it near his children who may be having to step up to help care for him? That type of thing is what I'm also thinking about too. Any other missing pieces?
Maybe starting the conversation about voice banking. I don't know how they are willing about it.
Yes, thank you for saying that. The speech pathologist in me's happy because I was waiting.
He's at a good point right now too.
He's at a great point right now, assuming he wants to do it.
SLP with very poor vocal hygiene this week, so sorry about my voice. I think about just the complexities and overwhelming feelings of this diagnosis, and then being faced with having to navigate the challenging healthcare system, multiple different pieces of assistive technology through multiple providers. It's like, it is a nightmare to navigate. So simplifying things as much as possible and trying to get people to buy in based on what their biggest need is. Is it, I just want to FaceTime with my family because I don't live near them. This piece of technology will allow you to do that. But then as a provider, knowing what else that one thing, that one piece of technology that you're going to provide has as far as opportunities beyond that, and accounting for the challenges that may be coming in the days to follow, I think is really important as a provider. So making sure that really you're accounting for that, but that, you know, you're not having to push people towards something because it's really ultimately their choice, but knowing that you can provide and outline and highlight there's some quality of life that can be maintained based on what you truly love and want to be able to do. And then connecting that with technology, I think is really important.
Yeah, I love that. And a piece that we purposely left out here is along the same lines of what you're talking about. Like, what really matters to this person, right? Is it I just want to keep my e-reading going and I want to FaceTime with my family and I want, because we all did, although we can do this and we can do that and we can add this and but going back to that person, like what really matters to you? What are your priorities? And then how do we simplify? The other thing we don't know is he's doing some of these things, but how comfortable is he with the technologies, right? So yeah, he's FaceTiming, so he's kind of familiar with iOS, but like I would want more information about those things to help direct decisions that you were talking about and conversations about what we can do. And I know for me, like the collaborative piece is always like I can't possibly keep tabs on all the technologies that talk well to each other and what don't anymore. And because this update changed and now you can't do that. And so that's where, that handoff that you talked about, the discussion, here's what I'm thinking. Here's what he told me. Well, that's not what he told me. Okay, wait a minute. Let's get aligned, everybody on the same page, and then figuring out how to get done, what matters to him. And this is somebody who, do we need to send in home health, OT, and speech for additional training sessions on all the technology? Because this is not somebody that we want to have to back and forth. And I'd much rather him learn it and do it in his environment. And so really thinking, okay, so we picked the stuff to meet the goals, but we're not done, is sort of the point I'm driving home. Sorry. This more like we're not done at that point. We need to make sure that he is comfortable, the family's involved. I mean, let's be honest, he might not be able to stay at home safely. That's a very real. And so all of those thoughts and processing back to that, who he is and that psychological peace and acceptance. Sometimes we want to do all the things right now and they say no. And then 3 months later, it's a yes. Okay. So now it's like, let's really go. Let's get moving. Yeah.
First clinic appointment is always, I have so much like empathy because I'm just like, this is so much information for a new diagnosis coming to clinic. You're hearing from all these different clinicians about all these different things. Sometimes I'm just like, I can talk to you about my service. It's kind of special, but like you took a lot of info in, like you can sit with that too. And just know that like kind of once I'm working with the clinicians too, we'll talk more individually, but like kind of let it simmer too. Not a lot of time to simmer, but simmer.
You want to bust through this last one a little quick and then whatever you're thinking, we want to hear about it. Not related to these cases or anything else. We'll definitely leave time.
Speed round.
Speed round. Yeah.
Okay.
Here we go.
So 54-year-old right-handed individual assigned male at birth, spinal cord injury with a traumatic brain injury. So this is from a motor vehicle accident, was in inpatient rehab, discharged home with partner. For the mobility, we've got power front wheel drive, left-handed joystick, so opposite. Technology has a touch stylus with phone and tablet. Complicated by cardiac arrest, so some complications, extubated, I struggle with that word. Communication, so yes, no with the head nod and shake, but inconsistent for everything else. So medical family questions. The main activities for the speed round: support face-to-face communication with family, and then support face-to-face communication with medical providers. Right now, it's just the inpatient hospital setting. So
yeah, we have this person with this baseline, impairment from the brain injury set up with all these awesome technologies to help functional status, home with the wife, doing well, and then really bad things happen, cardiac arrest, oral intubation for a prolonged period of time, extubated, damage to the vocal folds from that self-extubation, so not able to talk well. And now here we are. And do many of you work in an inpatient? What are your, yeah. So what brilliant ideas do you have to help in this situation? So we know he has brain injury. So we got to layer that in the complexity. What are you thinking? How do we help him communicate with his medical team, his family's preferences and stuff?
Question first, are you aware of any literacy skills?
I could make some up. I don't know. We don't know.
Okay, so I mean, and he still has the ability to point with the stylus.
He's restrained.
Oh.
We're back in rehab. He's back in. Yeah. He's restrained right now. Currently back in the rehab facility. Is that correct? For this
Inpatient.
Okay.
So my immediate thought is getting him a way to communicate through some kind of partner assisted scanning so that he has, if the yes and no nods are okay, has a way to participate in that communication.
What are other people thinking? I like that.
Without adding additional technology, it may not even be necessary at this point. Even just, seeing how much the patient actually knows, like if they, blink once for yes, twice for no, or have, two images or two objects and they can look to the one that's preferred. I mean, basic things like that. I don't.
Yes, yes, let me help you because you're speaking my language. So yes, the first thing, if you go back one, Olivia, we don't have consistent yes, no reliability. So we don't know if yes means yes and no means no. And so we put this case in here on purpose to sort of, I know it's a speed round, but drive home that point of the baseline cognitive language functioning. Until you can establish, and this is where you would likely weigh very heavily on your speech pathologist, reliability of yes, no is really important. Auditory confirming auditory comprehension. So we know he had a baseline TBI, but does he also now have an anoxic brain injury from the cardiac arrest and the time that he was down? I don't know. Right? He's also on some heavy, probably medications if he's restrained. So they're trying to get that under control. And so very much to your point, we would be doing things that were concrete, very relevant to him, and then throw in some zingers in there, some foils to, right. An intended choice. So that cause and effect piece. If I, all right, I'm old, but here we go. Does anybody remember an E-Tran board? Piece of plexiglass? They have them made. So we ended up using, because he was still restrained, he had too many lines. They were trying to get the restraints off him, but he was pulling everything. And they were working on that while we were working on other things. Because the big questions are, do you want us to, these were big, meaningful questions. Like, if you need to be intubated again, do you want to be? These are big. And he's got his wife who is, a surrogate and helpful, but you still want to include people in those conversations, right? So we used plexiglass E-Tran board, and we started with, ensuring he was attending to all the quadrants of the board. So with that, you watch their eyes. It's old school gaze selection, right? You look here, you look here, you look here, you look here. And so rather than having the alphabet board up there, because that is an original one, we modified it to family photos, things he didn't like. So look at so-and-so, find this, find that, so that we could confirm that he was understanding the words that were coming out of our mouths. And then we would hierarchically transition it to more complicated questions. Were you in the Army? And all four or either yes, no, or which branch of the military were you in? Look at it for me with written words. So to confirm that, okay, yes, when we say these concrete things about him, he's able to tell me yes. If I know he hates chocolate milk and one of the 4 written choices is chocolate milk and he picks it, he gets it. Because that's to verify that intent of communication and get some baseline information about cognitive language function to maximize communication. So reliability of yes, no, establishment. And then we were able to get him unrestrained, still trouble with the voice. We were able to take an iPad, get him back to some touch, smaller field than what he'd been used to. So that's the speed round end of that story. Sure, I'll take us home, since I like to talk. Sorry about that. I haven't even had that much caffeine today. So I think our take-home messages are all those personal details matter. That person, don't forget the person. and what matters to them and what they want, because that will help with the, device selection, maintenance, and efficacy down the road. But what they want is what matters. Picking, picking a piece of technology is only like one tiny part of this, honestly. How you train the use of that technology, it really does matter. This is bias, no empirical evidence whatsoever, but I would say probably at least 50% of the people that you see will learn from trial and error. What you're doing works. Just do those whole task models. They'll learn better and they'll remember it better. Again, bias, gross overgeneralization. But don't forget, there's a big section of people who don't learn and hold on to things very well that way. And we can't forget about them, because those are the people who maybe don't successfully use their technologies to support their goals as well as they could. And, rely on your friends. This kind of stuff takes a lot of work. I don't expect, my ATP friends, even though brilliant, to have the time and bandwidth to know how to train somebody to do something with a cognitive impairment like I've been trained and done my whole career. So even if I'm not involved, I've had PTs say, can you help me teach this patient how to safely use his power chair? Sure, I can write cognitive goals for that. Let's go. So don't just think about your collaborators and your friends in the assessment piece, is what I'm saying. Yeah.
To add slightly onto the last 2 points too, I think going with the idea of that ahead of time training schedule, I want to kind of plug an idea of it's okay if you don't know originally. I've had veterans come up to me and they ask a very specific question of how do I drag an app with voice control from one side to the other for a specific part of something? And I know that if I am training him particularly, he needs it to be laid out perfectly ahead of time. I can't trial it and error in front of him. So I have to say, I don't know, let me try it 1 second first and then go back to it. Or I've had those questions asked to me from other clinicians. So kind of reiterating those last 2 points of the training really, really matters. Kim said it a lot. I will also say it. And just being able to kind of go forward with that, work with your friends. Yeah.
Questions, thoughts, comments?
I will run around.
Oh, you're going to run around.
I'll run around.
I just had a thought when you were talking about this last case study. We had a guy with a TBI on our polytrauma unit, and pretty locked in. Wasn't sure if he was consciously thinking and making could communicate with the world. So one thing that was interesting with him is we were told by his spouse that he loved video games, and that was something that he did a lot of. So we tried out I drive racing game with him. And while he wasn't attending his regular communication board or speech board, we got a glimpse of him almost being able to do that with this racing game. So I kind of think out of the box when we're working with people like that, and just, hit up all your friends, like you said, and how can we help this person? So
Yeah, I love that. I have been known to do crazy things with communication devices, not communication related, in order to retrain visual attention and tracking and those fundamental skills to then actually be able to use it, even partner assisted, in a meaningful way. And so really scaling back and knowing the brain and how it works, and those underlying things, and then the motive, who the person is, that game. That's awesome. I love it. Other questions, thoughts, comments?